variety of cases. So yeah, so if you guys are able to at points, feel free to turn on your video so I can kind of tell who's talking. You guys can unmute and talk or raise your hand or talk in the chat, whatever is going to be easier for you all. So, so we're just kind of run through some cases with the various scenarios and feel free to ask other questions as we go. So we talked about two cases last time. So this is a third case. This is a 4-year-old male brought in to clinic due to being on the verge of being kicked out of a fourth daycare. He's extremely hyperactive and impulsive. He has very poor frustration tolerance, becomes aggressive with peers and adults. He'll run out into parking lots without regards for the situation. So what do we think are the treatment options for ADHD at this age? And what might you do?
So initially, I'm going to let someone else speak. I personally, when I look at a 4-year-old under 6 with really just behavioral issues, I'm inclined to use behavior modification first line. And Dr. Tam and I talk about ABA therapy. A lot of times we'll do ABA therapy with kids like this, some sort of behavior modification to start. As
So
far
you
as
do.
med treatment, obviously, if you're beyond the behavioral health piece,
uh,
and gave it 6 months trial, and we saw that we weren't improving, if that were the case, then I would use a short acting methylphenidate in a 4-year-old that was at risk if we tried all other options.
So what would your behavioral management look like, you think, for a 4-year-old? Who are you referring to, or what would you do for that?
So Dr. Tam would come into my room and would say, "Hey, what are we going to do here? We do behavior modification. Do you think ABA therapy is appropriate?" I'll defer to my psychologist about what the most appropriate behavioral modification would be for this child and how we would work into what kind of referral we can get and what kind of support we can get within the school and also outside of school. Dr. Tam, you want
But like as far as like specific techniques, like using very short directions, very short, clear directions, using directions one at a time, and also to like potentially playing games with like impulse control, like red light, green light, having like checklists or reminders, very clear rules, knowing like a schedule, knowing what's coming next. And also like the use of a timer, like to try to start teaching the concept of like we're doing this for 5 minutes and then that, or we're doing this for a minute and then that. So those are some of the things that come to mind.
Okay.
I have a
And
question.
yes.
Sorry. Yeah. So we know that some of these kids, their parents have ADHD too. So giving those instructions to the parents may be hard.
Mhm. It is true. And sometimes you have to treat the parent's ADHD as well. Sometimes you have to suggest to the parent, like you can ask the parent, like, how are they doing with these? A lot of times we'll ask just in general when kids with ADHD are having trouble, it's kind of like, what's your morning routine like? What's your afternoon routine like? I want to hear what is the mom, if there's this, like I talked to a mom this last week and she said, okay, I've got 4 kids. When they come home from school, I have them set up kind of like centers. They can each pick one activity to be in. I've got a timer set. They can switch at 15 minutes. We do that until 5 o'clock. Then we do baths. Each kid goes in one time, goes in one at a time to do their bath. We have dinner. Then after that, we have story time. We go to bed at 7 o'clock. She's got a clear routine, and she's like, oh yeah, sometimes we get off track with that, but she's got a routine, right? But if the parent can't tell you what the routine is or doesn't have a routine, then you might say like they really need to have a routine, reduces the cognitive burden for the parent and for the kid. And if the parent can't follow through, then yeah, the parent may need to get an appointment and get their own ADHD treated for sure. So, I would agree with all of those things for parent management training, and I would do those on the first daycare the kid was kicked out of or the second. By the time you get to the fourth daycare, this is not strictly environmental. And I would start a medicine with this kid for sure. I mean, this is unfortunately the kind of kid where part of your behavior treatment is sometimes one of those leashes, for a kid, which is sad. Like some kids are just so impulsive, parents can't keep their hands on them or hold them tight enough at all points. They loosen their grip a little and boom, the kid is out of their grip. So I would definitely think about starting a medicine and the therapy if the kid is not already in therapy. Hopefully, this kid would already be in. The parents might have already done some parent management training, which is sometimes in a group setting. Parent management training is sometimes individual. And yeah, you need to assess if the parents can follow through on those kind of recommendations. So parent management referral. Hopefully, he's already in or get that started, and then medication treatments. What would you guys be thinking of for a kid this age? I'm sorry, you guys, what do people say?
I would use short-acting methylphenidate
Yeah,
because
yeah,
you're not going to be able to get long-acting approved under 6 years of age with insurers. But Ritalin, methylphenidate, chewable, or some sort of product where we could get the kid probably a BID dosing schedule depending on how long school is
yeah,
going on.
probably. Yeah, things other people would do. Anything else?
I would also emphasize, especially with what you said about how the parent might also have ADHD. I would also emphasize kind of not completely empathizing, but like what's the word I want? Emphasizing that we understand it's hard
Validating, yeah,
and
validating.
we validate that you're having a really hard time getting your child to behave, that this must be really overwhelming for you, and we're going to work with you as best we can to help you work on this.
Yeah, and who else do they have supporting them? Are they letting other people give them breaks, that kind of thing for sure. So
Exactly. And if they're like a single parent or dealing with some of those just like issues to see what you can do about like when this happens at the other house, what can you do if they have any kind of power over that?
yeah. So so the first line treatment is behavioral therapy. So hopefully we would have already started that by the time they're on the fourth day care, but if not, getting that referred as well. So if behavioral therapy fails, then first line medication is usually a stimulant. And there are studies with young kids. There's one that's called the PATS trial. That's the preschool ADHD treatment study. They used methylphenidate immediate release. Preschoolers sometimes have a lower response. They don't always respond as well to a stimulant as an older kid, and they do have more side effects. They do also metabolize it more quickly sometimes. So there's a variety of caveats with it. So you're going to start really low and assess what their side effects are. They often have a little bit more trouble with insomnia, which is not helpful for anybody, or lower appetite. I would almost never use Vyvanse, a long acting in a preschooler like this, because Vyvanse is usually a 12-hour, but there was a recent study published in 2022 where they used Vyvanse in preschoolers, and they did show that it was still effective, although less effective as in older peers and some more side effects. So both the short-acting methylphenidate and the long-acting lisdexamfetamine, so a long-acting amphetamine, has been shown to have effects on ADHD symptoms. You could also use an alpha-2 agonist, right? Those are the short-acting alpha-2 agonists don't seem to have age-related guidelines. So short-acting guanfacine usually lasts between 8 to 12 hours for a kid. So giving some short-acting guanfacine, and the guanfacine is easy to chew or crush, so it's pretty easy to give it to a kid. You just have to watch, obviously, blood pressure, pulse, make sure the kid doesn't look like they're going to faint or pass out. So you have to kind of think about, what the insurance they have. Other insurers other than Medicaid might allow for a long-acting methylphenidate or the long-acting Vyvanse or a long-acting alpha-2 if the kid can swallow pills. But the guanfacine extended release, you have to be able to swallow a pill. So I think in practice, often when I see a kid like this who is just super hyper and impulsive, I would just use the immediate release guanfacine once a day to start with, and maybe even twice a day, and see where that gets us until the kid is a little bit older. So,
Dr. Stock, do you feel like with a little pressure from the AP, perhaps maybe start doing long-acting stimulants? I mean, it's to do double dosing either it's home at school. Is there a push to get this done, or is this anybody looking at this right now?
to allow long actings in little kids?
Yeah, at 4 and
No,
above. Yeah, yeah,
no, because a lot of the state insurances don't want to go against the FDA approvals, and the FDA approvals are just down to age 6, so they just say
right.
no based on the FDA approvals. They're
Uh,
just trying to be conservative with little kids and say we're not going to allow that. So it's unfortunate. Sometimes if they're not too expensive, I'll have people just go self-pay it, like the Metadate ER tablets are
mhm.
generally $10 to $20 a month. So or if you've got a kid who's adopted but has Medicaid as a secondary and the family has a little bit of means, I might give them a long acting, one of the cheaper long actings that they self-pay for methylphenidate long acting. But or sometimes I'll talk to families about what's affordable, what they want to do.
Right.
Not great. Okay, so another case. 10-year-old girl with ADHD presents for follow-up. She was recently started on Concerta 36 milligrams in the morning. Parents report decreased appetite, trouble sleeping at night. How would you approach either of those things? And we're going to assume it's working well, but her appetite's low. She's having trouble falling asleep.
The first, this open participation, but I'd want to know like
Well,
what was
you can wait and
what
let
was
other
the
people
previous
talk.
dose? What was her previous dose? Like we're on 27, we're on 18. She's
18
been
went to
on
36.
18. So I think you may have jumped a little too hard. Sometimes I like to go a little low, go slower. So 27, somewhere in between, maybe you might be able to help us out with the controlling your symptoms and maybe not overdoing it because you can overdo it sometimes. And you start seeing some of these side effects
Sure.
that go away with a little lower dose. So
Lower the dose.
yeah, so lower the dose is an option.
Mhm.
You could change the horse instead of riding this horse, ride a different horse, ride amphetamine, and switch it over either to Adderall XR. And I love Vyvanse because it lasts longer and it's just, it's a little easier on the appetite. So Vyvanse might be an option in this case. If let's say the 27 didn't work out or we were on 27 before we went to 36, I would do Vyvanse. That would be an option, or a non-stimulant would be another alternative, right? So you can do Strattera. You can try Strattera to see if that makes a difference, or Colbury, the newer one.
But more than likely, if methylphenidate is working for her, Concerta is among the longest acting of the methylphenidates. It's supposed to be 12 hours, although it isn't. So normally we would lower the dose of this one or switch to a shorter acting methylphenidate because if this is working well for her, we just shorten the duration. So Metadate CD, Metadate ER, one of those.
Yeah.
We could switch if it was not working, you could
Right.
switch the other category, switch to amphetamine or switch to a non-stimulant.
Do you think Vyvanse has less of an issue with appetite, or
No,
no? You don't think it does?
it's an amphetamine, so it's probably
Yeah.
worse.
Okay.
Although it depends for each person.
Yeah.
So what if her appetite wasn't the problem? It was just trouble sleeping. What do you guys do if it's like it's working well, eating okay, trouble sleeping?
I'll let someone answer. Let someone else answer.
Could you give it a little bit earlier in the morning?
You could potentially, depending on what time they're giving it. What
And
else?
also, note about Vyvanse, it's also used for binge eating disorder, so definitely affects the appetite a lot.
Well, it affects the behavior of eating, not necessarily the amount of food.
Right.
I mean, a lot of kids who don't have do well with Vyvanse with appetite versus stimulants like methylphenidate.
Can
So binge
also
eating disorder is a little different. There's different animal. Dr. Stockton will address that.
can also adjust her sleeping hygiene and give her extra magnesium,
Yeah, you
and
could.
that sometimes help.
Okay. Yeah, we could definitely talk about what's their bedtime routine. Do they have a good bedtime routine? What is that like? Once in a while I get a 10-year-old kid and the parents are like, yeah, she won't go to sleep. And then I find out they're trying to put the kid to bed at 7 o'clock at night. And I'm like, developmentally, that doesn't even make a lot of sense for a 10-year-old to go to bed at 7 o'clock at night. They just find it convenient to put the kid to bed because they want a few hours to do stuff themselves. But by fifth grade, I mean, a kid probably is going to go to bed closer to 8:30. So asking about what's going on, and you could adjust the bedtime, make sure there is a bedtime routine and a reasonable bedtime for sure. We could dose it earlier if that's feasible. What else do you guys do with poor sleep?
Well, so the flip side of that, Dr. Stock. So sometimes I'll have kids who have pretty well controlled ADHD during the school day, and towards the end of the day and after school they're not doing as well. I'll go from like a Folkland, for instance, a 50/50 to this particular med because it does last longer. So you can back it down to something like dexmethylphenidate and try to shorten the time. Maybe end it earlier in the day as opposed to go further in the day.
Yeah, okay. So we could use a shorter acting
Yeah.
to make so yeah, we could switch to a shorter acting methylphenidate. We could move it earlier. We could use a shorter acting. We could use a lower dose of this too to see if the lower dose worked. We can make sure the bedtime routine is good. Do you guys ever use any meds for sleep or recommend anything?
So if we maxed everything out, clonidine is the go-to, like a short-acting clonidine at bedtime.
Yeah.
That
So we'll
would
often
sleep.
use that. The short-acting clonidine, seems to last for about 2 to 3 hours to help with sedation. It often doesn't put them to sleep through the whole night, but if it's just trouble falling asleep, will often help them fall asleep. But it doesn't always help them stay asleep. But most kids with ADHD, so you want to find out, is it just falling asleep or is it both staying asleep and falling asleep? Just falling asleep, clonidine is great. Just at 0.1 or a 0.05, usually where we start. Anything else you guys use for sleep or recommend for sleep? As far as medication, again, I had
So
you guys said
I have,
magnesium.
yeah, magnesium, melatonin.
Melatonin.
She's melatonin.
I had a recent kiddo that, an autistic kid that just could not stay asleep, go to sleep, use Doxepin.
Yeah, well, yeah,
Of
because
course,
that's a different.
with my 1-800 number consultation.
Yeah, there's a it's a different matter. So like I said, you can
Yeah.
switch to shorter acting duration. You can switch to immediate release if you wanted to twice a day. We check the screen time, sleep hygiene. Hopefully, this kid doesn't have a phone that they're on at their 10. You could use melatonin to fall asleep. You use clonidine. You could use diphenhydramine if you thought that was okay. You know, in adults, all the over-the-counter sleeping medicines are diphenhydramine, but diphenhydramine, you guys would know better. Like, we don't use that in little kids that often. So, what age is appropriate to use diphenhydramine at night? At this age, you could use if she had trouble staying asleep. If they said she can't fall asleep, and she woke up a lot through the middle of the night, we might use mirtazapine, which is it's an antidepressant. It works on serotonin, but differently, and it's very hard to tolerate because of sleepiness. If you don't give it, you have to give it at night because of sleepiness. It does increase appetite. So sometimes for these kids who are having some trouble with appetite and insomnia, we might use that. You could use trazodone if she was having trouble staying asleep throughout the night, but we don't always use that in little kids. She's 10, so I might use it if they just said she couldn't stay asleep. Staying asleep is much harder. To get the kids to stay asleep through the night, I sometimes use the controlled release melatonin or trazodone or maybe mirtazapine. So you have lots of different options to deal with the insomnia. For appetite suppression, sometimes people feel like they can manage it well enough, giving the kids some supplements like Carnation instant breakfast drink or a protein supplement. Sometimes people skip meals. I mean, sorry, not skip meals, skip the stimulant on non-school days, like on weekends. So if you skip on the weekends, if the kid seems to function okay in the rest of their daily life and can skip on the weekends, they will, or skip on non-school days like spring break, Christmas break, summers, kids will catch up in their weight. They don't usually catch up in their height if their height is also being suppressed, but they will catch up in their weight with holidays. Sometimes you just have to wait till the kid is hungry. So sometimes parents will say, well, they're not hungry at dinner, but then at 8 o'clock at night, they're hungry and they want to eat a peanut butter and jelly sandwich. And we'll talk to them about like saving the dinner. Don't throw dinner away. Just cover it up, heat it back up when the kid is hungry. And then when the kid is hungry at 8 o'clock at night or 9 o'clock at night, they eat their dinner at that point instead of giving them some kind of processed snack or whatever. And sometimes we'll use mirtazapine, sometimes we'll use cyproheptadine to boost appetite. So there's all those things that you could do to address insomnia and appetite suppression. Any other kind of thoughts about appetite suppression and insomnia? Do you guys want to mention? Should go a little faster through these cases. Okay, 10-year-old girl with ADHD. She was recently started on Concerta 36. She's doing well in class, but struggling to focus to complete her homework. So what do you do if it's like working in school, but can't really do her homework very well?
Sometimes at the end of the day, we can add maybe a short-acting methylphenidate to take after school so they get homework time, 4 hours, and get them through that homework, and then use it maybe Monday through Thursday, not on the times if there's no homework present. So that's something I might consider.
Right, for sure. You have to kind of find out when does the kid get home? Are they going to an aftercare, not getting home until 6:30 or 7? Like, kind of have to figure out what time is dinner, what time are they home. But a kind of booster of an immediate release stimulant after school is definitely an option. So we could add an IR stimulant. Sometimes we can adjust the medicine timing, like take the focal end slightly later if they're taking it. If there's buffer, sometimes you can take it slightly later in the day. You could switch her from focal and XR to a longer acting stimulant, right? You could use an you could use an alpha-2 agonist if the parents say like, her appetite is already too suppressed. We don't want to add more stimulant dose, or we're really concerned she already isn't falling asleep quite as easily. We don't want to take another stimulant closer to bedtime. Could use a long-acting alpha-2, and put in here long-acting, but you could use a long-acting alpha-2 to see if that helped attention and focus just enough to get through homework. And obviously you could pay attention to where are they doing homework? Do they need to adjust the environment where the kid is to minimize distractions? Or think about when the kid is doing homework. Because a lot of kids, of course, want to come home and relax and play video games and do their homework maybe as late as possible and hopefully just not have to do it at all, versus a kid who has ADHD may need to come home, not take much of a break, do their homework while the stimulant's still working, and then have their free time later in the afternoon. So sometimes just figuring out if it's a matter of them not doing their homework until pretty late.
Dr. Stock, a nuance in this case, the 10-year-old, not all 10-year-olds swallow pills. So like the switch to Concerta may not work because focally they're opening up the capsule, they're putting it in food. What longer acting methylphenidate can we use that's not a 50-50 like Focalin that might go a little longer that can open up into a, let's say, yogurt or pudding for that matter? Do you have any suggestions?
I don't think there is anything longer. You could use a Ditrona patch, but there's nothing longer that sprinkles. All of the others are going to be pretty much the same. Focalin XR, as far as I'm concerned, Focalin XR, Cotempla, Abtensio, Quillavent, Quilichu, Ritalin LA, Metadate CR, Metadate ED, they're all kind of the same, 6 to 8 hours. You could switch among them and see, like, if you just need like a little extra focus, like this is working till about 4 o'clock, we just need like a half hour to an hour more, you could mess around among those, but you're probably not going to get that much difference.
Yeah. So you feel like Quilichu or Quillavant is not, it's more of an 8, it's less than 12 hours is what you're
It is
saying.
definitely less than 12 hours. It's like an immediate release. It's definitely less than 12 hours. Now, if the kid has commercial insurance, Blue Cross Blue Shield, that and something like that, you can use Astaris. Astaris is longer acting Focalin, works wonderfully, lasts 12 hours. You can use Focalin XR BID. We use it BID all the time. If if the kid and the parents say it's only lasting, let's say 6 hours, they're taking it at 6 o'clock in the morning, it's lasting until noon. They could take another Focalin XR10 at noon and it will last till 6 o'clock at night. That's not so much of a problem. So, so we do sometimes use Focalin XR BID. I wouldn't say I do it that often in a 10-year-old, but I do it plenty of times in teenagers, older kids who have later bedtimes, that kind of thing. So you can.
The other thing too, Dr. Sanders, let me interrupt you here, but the thing is, what for the folks that are on the Echo, this is a great time where you're struggling with what to do and you're not really sure, and there's these nuances. This is where you call the 1-800 number. It's a perfect opportunity to talk to our colleagues at USF because they can direct us and give us some ideas. So maybe thinking outside the box. So this is a perfect opportunity to say, hey, what do I do here? I'm not sure. So this is, I'm thinking a commercial, but it's a 1-800 number. Call and get some guidance.
Yeah, so similar to that, I forgot to change hide the options on this slide. So okay, so we'll just talk through it. 10-year-old girl with ADHD presents for follow-up. She was recently started on Focalin XR10. She's working well, but wears off by 1 p.m. She's taking it at 6 o'clock in the morning when the family leaves the home to get to before care. And what are our options? So we could give her Focalin IR 5 milligrams at school at noon. Because remember, Focalin XR is basically 5 milligrams now, 5 milligrams 4 hours later. So she's kind of getting 5 milligram increments that are working well. So we could give her an immediate release 5 milligrams at school if the family wanted to. Certainly one option. She may or may not need another dose after school. So we could use the BID XR option. The other thing people don't always think about is I have some families that they give the kid the short acting at home and they take the long acting to school. And they might have the kid take the long acting Focalin XR at school at 9 o'clock. Like sometimes kind of as the kid is coming in, start of the school day, they'll go to the nurse's station or go to the office, get their medicine pretty early in the school day, and then it carries them through the school day with less disruptions in their school day. So that can also be done. Sometimes kids, like the last example we were talking about, the kid who was wearing off too soon. Let's just say they went to aftercare. Well, aftercare won't usually give a medication. So you can't usually use a Focalin immediate release booster after school at like an aftercare program at 3 o'clock. They won't do it, or 4 o'clock. But you can use this kind of strategy where they take that booster in the morning. They take a long acting at school that covers them through the aftercare time. So there is that kind of option as well to do that. or like I said, change to a longer acting preparation. So really there's lots of different ways to do the timing. I've got some kids who prefer to do their homework in the morning. Some people out there in the world are morning people and they're better in the morning. So some kids, they get up, they take an IR medication, they do an hour or two of homework in the morning and kind of go on with their school day. So sometimes they're taking the extended release right as they're getting out of the car to go to middle school or actually at school. So anybody else ever done this? Or anybody else ever given an IR in the morning first and shifted the
Yeah.
XR later?
I used to do that a lot with Concert initially because it takes so long to kick in that sometimes we'd have to give a little short acting before the school bus so they can get to school. Otherwise, they get kicked off the bus before they even get to school. So
Yes.
that was some of the things that we did.
Yeah,
I mean, I've done that.
tremendously common with Daytrana patch. That patch takes 2 hours to absorb through the skin. So some parents sneak in the room in the morning and put the patch on the kid while the kid's still asleep at 5 o'clock in the morning, get themselves ready, and that's going better by the time the kid gets up. But some families just cannot back it up early enough. And then they'll take the immediate release in the morning, put the patch on at the same time. But yeah, for Concerta, for Vyvanse, who has to get activated in the stomach, sometimes taking an immediate release in the
There's
morning.
a lot. So this patient who's actually at 6 a.m., obviously the early risers, kids got to get ready, going to school, the bus, etc. Is there a place for Jornay here where they talk about kicking in the morning, giving it at
Yeah,
8:30 at night, kicks in the morning. Does it last 12 hours as they say?
never
I've been
does.
starting to use it more, but I'm going with the flow and just checking
Yeah,
it out,
so
just like
that's a different one of our cases, but but we may or may not get to that. So the different one of the cases is yes, certainly you could give Jornay at night. Also for this problem, I guess you could give Jornay at night. I would say
Right.
Jornay is formulated so that you take it at 9 o'clock at night. It starts
Mhm.
to absorb by around 5 o'clock in the morning. Should be active in the system by like 6 o'clock in the morning, and it's supposed to last until 5 or 6. So like
Right.
12 hours of action, it's supposed to last till like 5 or 6. I don't think it ever does. Almost
Right.
every child I have taking Jornay takes a booster in the afternoon, but it is tremendous for morning difficulties. Like families that say the mornings are just utter chaos, that the kid wakes up, I give him his pill, by the time it's kicked in, the dog is crying, the siblings are crying, mom is in tears because the kid has just been wild. Jornay works well. So let me just see what else
Thank
we
you.
chat here. Um, so I'm just looking at this chat here. A question about split households. One parent is taking advice, but the other doesn't follow through, doesn't have structure, doesn't believe the child. So, um, you know, when one parent doesn't acknowledge the difficulties, the best you can do is you just have to figure out what is it that you can do. Kids don't have to have the exact same parenting at households. Kids have different structures and different kids do a decent job of knowing that I act like this at grandma. These are the rules at grandma's house. These are the rules at school. These are the rules at mom's house, dad's house, and they alter their behavior for that. And people can have very different strategies with their kids. I think trying to get the two households to do the same thing is just a losing proposition. I think you can work with each parent on what can you do at your house to address the problems that you're having at your house. And then school is a zone that they both need to work on, right? So if your kid is having trouble at school on the days when they're at your house and you didn't give medicines, we need to take that for what it is, that the kid is having trouble at school on the days when they're with you. So we don't want the kid to. So I try to talk to the parents about like, when your kid is at school and they're getting in trouble, that begins to affect their self-esteem. And at some point, kids stop wanting to try. They begin to just give up, learn helplessness. I'm not even going to try. In fact, I'm just going to throw spitballs because that's what I'm good at. And I'm just gonna like see how fast I can get kicked out of class because I'm good at misbehaving. And so they start making a game out of misbehaving or pissing off other kids. They begin to feel like, and they internalize, I'm a screw up. I try because kids with ADHD, they look like they're not trying, but they are trying. They're just making poor decisions and poor mistakes. And so it wears away on their self-esteem. Sometimes they're defensive enough to try to cover that up by like being bad on purpose, but it is hurting their self-esteem and it is hurting their learning. So eventually you just try to work with that parent who doesn't think that their kid is having difficulties about, well, what's happening at school? Now, if the kid is behaving fine at school, learning fine at school, behaving fine at that parent's house, fine. That just means that I probably cannot use a high dose of a alpha 2 agonist, because that you shouldn't come off of abruptly, right? You really want to taper alpha 2 agonists. So if I'm going to use an alpha 2 agonist, I'm not really going to be able to go above, let's say, 1 milligram of guanfacine or 1.0 of clonidine. Because, if they're at mom's house and she's giving them the methylphenidate and guanfacine ER 0.1, and then they go to dad's house and they don't take any of that, it's safe enough. Maybe it may not be a deal, but it's safe enough. Now, if I think that they're off of that and they're acting up and dad is beating them, or dad is exerting a lot of harsh punishment to try to keep the kid in line, that's a different matter for me to talk to the parent about what the downsides are to that level of how they're helping the kid, how they're getting the kid to comply, that may not be good in the long run for the kid. Again, for the kid's self-esteem, can be it can be trauma inducing, the whole notion that like you can end up hurting a kid when you don't mean to, like we don't encourage corporal punishment for lots of reasons, teaches you to hit, teaches you to be, that hitting's okay when you're angry, all those kinds of things, gets the kid mad at you rather than trying to reflect on their own behavior. So you could try to talk to that parent. But I don't try to get both parents to do the same thing at their houses. Whenever a parent doesn't believe in the treatment or whatever, I try to reach out to that parent and talk to them about what their concerns are. Because I'll more than often one parent comes in and says to me, oh, the dad won't do it. He doesn't believe in ADHD. He doesn't want this, blah, blah, blah. He or she, blah, 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 blah. And I'll say, bring that parent in. Sometimes they're even married. Bring that parent in or give me that parent's number. They're not going to come. They're not going to talk to you, which is usually incorrect. My experience over the last 30 years is that all parents are concerned about how their kid is doing and the messages they're being given. And so most parents who are the dissenting parent, if I just call them and say, like, I'd like you to come in for an appointment, or I want to talk to you about your child and get your perspective, because I'm hearing a lot of concerns about how he's doing, and I want to get your perspective. I want to know what you're seeing and most of the time the parent is very happy to come in and make an appointment. Now, me personally, I think you can bill. My reading of the rules is that you can bill without the child or the patient directly present for an appointment. You just bill it based on time, not on medical decision making. So I meet with parents all the time. Bill insurances have not had a problem. And when you read the CPT codes, it says that it needs to be with the parent and/or caregivers or people related to the family. So I will sometimes I don't like to spend those conversations for free. So I try to get the parent to come in, or I can still do video visits. So I'll do a video visit with the parent, the dissenting parent, and find out what their perspective is and see where I can insert that if the kid's self-esteem is taking a hit, if they're beginning to hate school, or if they're getting ostracized. Those three things you have a really hard time. I'll tell parents, that's just my line in the sand. You got to treat. Like if the kid is getting ostracized from other peers, you can treat them and you won't reverse that. You're just going to have to move or change schools, right? So you don't want the kid to no longer be liked by the other kids or to hate school, because you're not going to reverse that very quickly, or to begin to say bad things about themselves. So those are all kinds of things. So that's a little bit about the parents. So so that's just some things around parents. And when parents are divorced, they have to talk to each other about what they're going to do. And if they have questions, they can always come to the appointment or that kind of thing. But I'm not going to necessarily always do separate appointments. But if I feel like I'm getting told that one parent is resistant and that parent's not there, I want to reach out to them independently. Because I found almost every time that parent is like, oh, I'm so glad you asked me, because nobody seems to care about my perspective. Here's what my worry is. Sometimes they're just like, my brother was a cocaine addict and I don't want my son to become dependent on stimulants. So then I can go through that discussion with them. Or they can say, well, how do I know that this isn't normal boy behavior? And I'll say, because the teacher Vanderbilt says, and this teacher has been teaching for 20 years and has seen a ton of 10-year-old boys or whatever. So you can kind of go through a little bit with the parent. So. All right, let's do a couple other cases. So 8-year-old boy has been started on Vyvanse for ADHD, is doing well at school. Behavior at home is not improved as the Vyvanse has worn off by the time he's picked up from aftercare. His high energy levels agitate his siblings and the family dog. He makes a mess everywhere he goes in the house. He has trouble following directions. Parents feel everyone is on the edge of tears by bedtime. So what are the options to tweak his treatment? So I think we've kind of gone over these, right? We could refer them for family therapy or PMT, right? We could add an alpha 2 agonist, if we feel like, or we could add a short acting stimulant. We could add a medication in the afternoon. Really, the long acting alpha 2s can be given any time of the day. The studies with alpha 2 agonists on their own, like guanfacine ER, Intuniv, they gave it in the morning, they gave it midday, they gave it in the evening. It doesn't matter. It's a 24-hour-a-day medicine. Any timing of it, whatever's tolerated best, worked fine. So you could add Intuniv in the morning with the Vyvanse, and that would probably help. Sometimes families want to, from a placebo effect standpoint, take it in the afternoon so they feel like, okay, I've done something to medicate his ADHD at this point. So either way. So I think we kind of talked about that, all different ways to time immediate release, long-acting and short-acting stimulants, as well as adding in long or short-acting alpha 2s. So there's just a ton of different ways to do that.
Dr. Stock,
Yeah.
with the use of the alpha 2s, long-acting alpha 2 and Vyvanse, that was FDA approved for combined treatment, correct?
Yes, the long-acting alpha 2 agonists are FDA approved to take with any stimulant.
Any stimulant, not just
Any stimulant.
Vyvanse. Okay.
Yeah, any stimulant. Yeah. So that's one of our few combination treatments that's actually FDA approved, which is awesome to have
Right.
some things that are approved. So you can tell parents it's approved to take by itself. It's approved. This combination is actually approved. Totally fine.
Yep. Yeah, kind of smooths out the edges. And that's one of the things, it's really helpful because we're not doing an off-label use of a drug. We're actually, it's approved. It's FDA approval to be able to use in combination when necessary.
So somebody asked something about the best medicines, I think, for an ADHD kid who's 12 and is short, and the parents are short, and there's concerns about growth. Yeah. I think, sorry, I'm skipping over to this noticing this question about growth. I think you just would want to monitor. I don't think there is an answer specifically about growth. I'll say that several studies have shown that looking at their growth trajectories, from a young age, you give a stimulant, the kids are about a half inch, couple centimeters shorter than predicted on their growth curve. So it's not usually like we made them 6 inches shorter than we thought they were going to be. It might be an inch, half inch to an inch shorter than expected. But if your dad is 5'4", my dad was 5'6". Every inch mattered to my brother, who only ended up being 5'6", right? That was important. 5'5" versus 5'6" would be a huge difference for a shorter boy. So you just kind of, you have to monitor that curve. That tracks a little bit with weight and appetite. Sometimes that's just related to calories. So yeah, you might be more likely to use short-acting stimulants and leveraging the non-stimulants. So using alpha 2 agonists or using atomoxetine or something, and just watching those growth curves really carefully, using short actings or non-stimulants. I don't think that you could say that one versus another is more likely to cause growth deceleration, other than any of it could cause it. The growth deceleration in height is typically the worst in the first 2 years of treatment. So you want to be right from the beginning, really monitoring and seeing, is the kid shifting on those growth curves at all. So yeah.
And you pointed out it's more, I think, more of a manifestation of nutrition than it is maybe just it's not suppression of growth hormone. You're not eating as much, and you may not be growing as well.
They seem tied together, although there may be some other independent, effect. But you don't usually see that a kid was shorter and didn't have appetite suppression. That usually you're seeing both together: appetite suppression, weight suppression, height suppression.
Right.
All there.
Right.
So I think, so you just want to track that carefully, and, maybe use shorter actings, keep the dose as low as possible, because it is somewhat dose dependent. So keep the dose as low as possible, use shorter actings. Like I said, they don't show that taking breaks really helps the height. Does help the weight. So it's just hard to say. I think you just have to watch that.
Mm-hmm.
All right, so this was a different case. Somebody other than this is kind of what Dr. Anzalone asked about earlier. So 8-year-old boy has been started on Vyvanse, 20 milligrams for ADHD, doing well at school. behavior at home is not improved. His mornings are particularly tough. His high energy level agitates his siblings and the family dog. I feel like the dog is often a kind of a problem in the families. The kid makes a mess everywhere he goes in the house. He's trouble following directions. His parents feel like everybody's on the edge of tears by the time his medicine kicks in. So what are the options to tweak his treatment? So we've talked about this somewhat. I think you can refer for, parent management training to make sure they've got a decent structure to everything. You could add a long-acting alpha-2 agonist so that maybe that's working 24 hours a day, maybe taking one in the afternoon or evening, so it's still kind of at peak levels. Sometimes with the alpha-2s, what you see is the blood level is falling, right? The flow goes up and then comes down a little bit, and you're trying to dose it so that you don't get valleys in there, but you just sort of get a little bit of blood level variation throughout the day. So sometimes the behavior is worse right before they take the next long-acting alpha-2 agonist dose. So in this case, if the mornings are a problem, you might have him taking that afternoon alpha-2 agonist or an evening alpha-2 agonist so that in the morning he's kind of covered with a good peak level. So you could do that. You could add an immediate release amphetamine to take right before he gets out of bed, or this is where you could change to Jornay, switch categories and give the evening medication. So I know you can get Jornay PM on Medicaid. I think you might have to have failed at least 2 other ADHD medicines, but they don't have to be stimulants. They could be failing an alpha-2 and failing one stimulant, and then, and failing meaning you can't tolerate it, or it didn't work. So they could. So if you've had tried 2 other ADHD options, you can get the prior authorization for Jornay PM. So, any questions? Any other questions about Jornay PM that you guys had? Have other people used it?
Has anyone else had experience with Jornay? Other than myself, Dr. DeVera, Dr. Brown, who else is on there? Any other champions, ADHD champions have used Jornay? Experience? You're mute. Unmute yourself.
I have a couple
No?
other cases, so I guess we have like
Yeah,
8
okay.
minutes, so
All
we'll
right.
see.
Yeah,
14-year-old male with ADHD presents with declining grades. He took several stimulant medicines in elementary school, but did not tolerate them. So stimulants didn't work well. Alpha-2 resulted in bradycardia. Atomoxetine gave him nausea, didn't get better with food. Viloxazine made him too tired. So he was doing okay in a private K-8 school, but now is in public school for 9th grade. He has a 504 plan, but he's struggling to stay organized. He's resisting staying after school to ask teachers for assistance. His motivation seems very low. So what else could we do to help his ADHD or address issues for this kid?
Dr. Stock, one of the things I've recognized is that if you failed stimulants when you're younger, doesn't mean you're going to fail when you're older. Sometimes it's worthwhile trying again.
Depends a little bit what you mean. Lots of kids
Yeah,
don't tolerate them when they're younger. They'll get aggressive or irritable. Their
yeah,
mood is worse. And then a lot of times, the older you get, the less mood issues you have. So if
yeah.
somebody failed because of anger,
Okay.
it's worth it to retry after puberty. If it
Okay.
never worked to help them focus, I don't know if
Right.
that gets any better.
That's not going to work. No. I would say if
So
it, when Dr. DeVera, go ahead.
sorry, so should we check to see if he has depression? Because his motivation for change seems low, so.
Yeah, absolutely. So you definitely might want to have them do a PHQ-9 or ask some other questions about depression, certainly. And, think about if if there is depression now, that could worsen his concentration. So we could treat any depression if it's there to help his concentration. Any other thoughts?
Yeah, I think he does better with the smaller group, like the small private school.
Mm-hmm.
And I think maybe when he was with the big school, that kind of affected him. So the 504 plan can give him time to do academics, but it doesn't give him that one-on-one, I think, as much. So there's something to be looked at.
For sure. So what else can they think over that? Some schools offer the option of a study hall, which sometimes helps kids at school be in that context, try to get organized, do some work. Sometimes they can build into the day.
Private tutoring, yeah, stuff like that.
Yeah, sometimes during the school day, they can build in meeting with like a academic advisor or sometimes schools have like their homeroom teacher that is accessible at some point during the school day to help the kid get organized. Okay, what's your homework? Where's all, if you turned everything in, kind of go over whatever with them. Yes, the family could maybe hire a tutor if the kid would do that, because some kids just don't want to stay after school. So definitely all those things, going to another private small school if possible. There's such a thing as ADHD coaches. They're not covered by insurance, but they work not like I'm going to teach you math, but I'm going to teach you study skills, note-taking skills, organizational skills, how to use a planner, how to check Canvas every day, that kind of thing. So if the family has resources, they could do that, but those are things that are expensive.
I would also ask if he's involved in any kind of activity, like physical activities. 14-year-old, he's hormonal, so he needs to be active and involved. And
oh yeah. So sleep, does this kid have any sleep apnea? Is this kid sleeping enough, and is he physically active? Because, being physically active does help you concentrate, focus, feel energetic enough, make you sleep well, feel energetic enough during the day. So definitely. Okay. And then off-label medicines for ADHD would include bupropion and tricyclic antidepressants. So bupropion is a selective norepinephrine reuptake inhibitor. That is the same thing that atomoxetine and viloxazine are. They increase norepinephrine. Actually, that's what methylphenidate does too. It increases norepinephrine in your brain. So in these teenagers that where I'm questioning depression, sometimes I'll give them bupropion. Concentration usually improves within 2 weeks on bupropion. I'd say about half of them improve on the bupropion extended release 150 dose. Sometimes I need to go to the 300 milligram dose, but sometimes kids, they can suppress appetite a little, but not as dramatically as a stimulant. Can cause insomnia, but again, not as dramatically as a stimulant. So, it could cause nausea, but it's not likely to make them tired. So if we were wanting to go with a non-stimulant route, or wondering if there's some depression in there, we get some indication there's some depression, we could use bupropion. It is off-label for everything in a kid this age. So it's off-label for ADHD, it's off-label for depression, but I'll tell you, we use a ton of it in child psychiatry, and it works pretty well. Technically, the shorter acting of the bupropion formulations works better for concentration. We still tend to use the extended release, but there is an SR version, which is like a 12-hour version, and there's an immediate release version. So sometimes we use the SR version, the 12-hour version, and just use it once a day, and it will still work. Tricyclic antidepressants, like we will usually use nortriptyline because it is the least anticholinergic, so it's the least likely to cause like blurry vision, dry mouth, constipation, sleepiness. So we will sometimes use a tricyclic. So any thoughts about using bupropion or tricyclics? Bupropion you're not supposed to take if you've had a seizure. So if you've had like febrile seizures in infancy, probably okay. But if you've had other seizures, you shouldn't give it. I would also be cautious in kids who've had head trauma or repeated concussions, because I have had some kids with concussions. I've had adults who've had a history of concussions who then get seizures on bupropion. So I'd be a little careful with that. But if they've not had any head injuries or seizures, you could use bupropion.
It's kind of great if a kid says, "Oh, I'm vaping now." Try smoke cessation. Wellbutrin, be like a 2-for-1.
Yeah, you could do that. Yeah. Vaping is a whole other issue, right? Because what are they vaping? Are they vaping nicotine? Are they vaping cannabis?
Right.
And so you certainly could wonder,
Yeah.
because when I ask all about, like, interview the kids separately, talk about substances. We may or may not have said this already, but people with ADHD have higher rates of substance use as compared to the average population. So in the adult population, 15% of adults have a substance use problem, higher than that if they've had a history of ADHD. Most studies seem to show that if you don't treat the ADHD, their rates of substance use are higher. So sometimes by the time these kids are adults and they're using cannabis, people say, "Oh, I'm not going to treat their ADHD because they're using, cannabis." But usually, if you improve their ADHD, you reduce their substance use. So, granted, as an adult if they're using cannabis or something, you might want to use a non-stimulant, and that often can work well. So let's see. Do I have other? Okay, so sorry, norepinephrine reuptake inhibitor. The dose is usually 3 to 7 milligrams per kilogram per day. Watch for seizures. Suicide is listed in the package insert because it's an antidepressant. So So I did have other tricyclics. I think I just said that. Tricyclics, we use norepinephrine. We use nortriptyline for lowest sedation, lowest anticholinergic effects. Start at 25 a day. Increase as needed up to every 5 to 7 days. If you get to 3 milligrams per kilogram per day, you would want to do an EKG to check for QTC prolongation. And the max dose is usually 5 milligrams per kilogram per day, right? So we kind of look at the EKG, and you might do a blood level as well when you get to 3 milligrams per kilogram. If we stop this, we taper it due to risk for a cholinergic rebound. So, we probably already said that. So I do have other cases I could go through, but I don't know what everybody's time is. Do you guys want me to stop here?
Just do one more case, that'd be great. This one, because we started a little late. If you don't mind, just one more.
9-year-old male with ADHD and oppositional defiant disorder taking Vyvanse 30 and guanfacine ER2. Focus is better, but he's less hyper, but he continues to have poor frustration tolerance. He becomes agitated quickly, anger going from 0 to 60 with verbal and physical aggression. He's got frequent detention and suspensions due to peer conflicts. So what would you do next? What do you do if you're using a stimulant and a non-stimulant? Focus and hyperactivity are a little bit better, but a lot of impulse control problems with aggression.
So,
Angelina
Dr.
can't
Scott,
answer. No, you
I
can't
can't answer this one because I'll give you my opinion, but
Decrease
somebody needs to answer this one.
the Vyvanse a little bit and see if that helps.
If you could ask whether they thought it got worse. If they're saying, no, it's not any worse, this isn't better, then I wouldn't mess with it. But you can certainly explore that. Are either of these medicines worsening aggression versus it just hasn't gotten better?
Dr. Stock, 2 milligrams of intuitive is kind of low. So
Depends on the kid's
maybe
weight.
increasing the guanfacine possibly.
If the kid's weight is high enough, you got to go 0.12 milligrams per kilogram is the max on the alpha 2 agonist. So it depends on his weight.
Yeah. So he's an appropriate dose of Intune,
Right.
yeah?
Yeah, if we feel like he's kind of maxed on the guanfacine. But yeah, you could increase the guanfacine if he's not maxed on that.
Has he tried other stimulants other than Vyvanse?
Right, so that'd be a good question. We could certainly try a methylphenidate medication if he's not tried one.
Sometimes the amphetamines tend to get a little moody. Get you a little bit more aggressive and moody, and
Yeah.
they seem to have less tolerance. They get a little bit moody.
Yeah, so that's where we would definitely want to ask the parent, like if they're saying, no, this was all there before,
Right.
could try another medication, but if it's all there before, just this part is still a problem, you might do something else.
And the other thing is to talk about non-stimulants as opposed to just go all non-stimulant and get away from the stimulant completely. Because somebody pointed out that maybe stimulants does make him, frustrated. Maybe he doesn't tolerate it.
Again,
So
you want to ask,
non-stimulant.
you'd want to ask if this is worse, like because kids with ADHD have low frustration tolerance. So lots of kids who are not getting ADHD treatment, if they're untreated, boom, they have high, quick, angry outbursts. So if his baseline is boom, quick, angry outbursts, and this just that part has not improved, we want to keep treating. But if this is brand new or this is worse, sure, back off. But you would just want to ask, where was this, right? So, if we're assuming that this is not a medicine side effect, it's a piece we haven't resolved yet.
You can do atypicals, even risperidone. If somebody's truly aggressive, I mean, that's something to think about as well.
Right. Obviously, we can add, he's 9, you could add PMT or family therapy if they haven't done it. So if the kid, kids with ADHD don't need any treatment themselves. They don't benefit from behavioral treatment themselves unless they have oppositional behavior or anxiety, right? So this kid has oppositional behavior. So have they had any therapy that involves him? So you could definitely do that. Use there are rating scales to track irritability and aggression. They're in the public domain that are brief. So you could use a rating scale to kind of characterize that better. The MOAS or the affective reactivity index. They're both pretty short things. Yeah, and you could add risperidone, you could add aripiprazole, or you could add valproic acid, kind of each of these kind of starting at the lowest dose that you can. But really, there's been a number of studies looking at ADHD and aggression, impulsive aggression. And if you can't get it under control with therapy and a stimulant and a non-stimulant, then risperidone or valproic acid are usually the things people go to. Risperidone, you've got the risk of gynecomastia. So sometimes we'll use aripiprazole instead, but one of those three is typically where you would go. I mean, sometimes I'll do something different if a kid won't tolerate blood draws, because valproic acid, you got to get every 6-month blood draws. You got to get a level and check their liver function test and their CBC. If they won't do that, sometimes we'll use like oxcarbazepine, trileptal. Sometimes we'll use that because it's not as imperative that you get blood work, although you still probably want the blood work. Risperidone and aripiprazole, we still want blood work because we're usually looking at lipids and blood glucose and liver function tests. So those are all become a bit of a problem because of the blood work that's required. Risperidone, you would start just like at 0.25 once a day, somewhere in the range of 0.125 to 1 milligram. Aripiprazole, you start at 2 milligrams a day, maybe even 1 milligram a day. Valproic acid, your target for behavior control is usually 20 milligrams per kilogram per day with a blood level of 80 to 100. So you usually start slow and work your way up on the long acting of that. So you get baseline CMP, CBC lipids. You would get prolactin baseline if you're using risperidone. And you got to watch for weight gain. If they've gained more than 5% of their body weight, so you got to kind of calculate that at the start outgo. So I'll try to remember to say to patients, okay, we're going to start risperidone. You weigh this much today. If you're hungry, I want to know that. And if you're gaining weight, if we say, I'll calculate it and say, if we weight gain more than 4 pounds for you or 10 pounds for you, whatever 5% is, we're going to need to talk about changing to something different. So, because kids sometimes gain weight hand over fist with risperidone or aripiprazole, and you can put 30 pounds on a kid in 30 days, very quickly. So you want to kind of know what's your threshold. The FDA reports weight gain as a side effect if it's more than 7% of your baseline body weight. So usually for me, if they're gaining more than 5%, I feel like we got to put the brakes on and do something different, lower the dose, make a change, something like that. So that's what I had then. So you can use stimulants in preschoolers, although it's not as effective and they have more side effects. Stimulants can worsen tics about half of the time. To cover the day, you might need any number of creative combinations of long and short-acting stimulants and long or short-acting alpha-2s. For teens, bupropion can be used if a stimulant or other treatments are not tolerated or if there's definite comorbid depression. You can use tricyclic antidepressants. They can be very effective, but they are harder to take because of side effects and cardiac risk. And if they're aggressive, you can consider an antipsychotic, risperidone or aripiprazole or valproic acid. So get labs and watch for weight gain. Some kind of the summary of some stimulant or some ADHD cases. If you guys have a case scenario we haven't covered, maybe you want to write a note to Dr. Anzalone or Dr. Tam. I guess maybe you guys could decide who you wanted that to go to. If there's other scenarios you wanted us to cover at future meetings or have.
I would love for us to present a few cases to you and just see what we're doing with those cases. Any of you have problematic children, if 1 or 2 cases, we can get them to Dr. Tam. We can present this to Dr. Stock and utilize her to kind of give us some insights in what we're doing. This is, by the way, phenomenal. I'm sure everyone would agree. The other caveat as far as about valproic acid, when you talk about 80 to 100, I just want to make sure that people realize when you're looking at the therapeutic seizure threshold for the trough level is like 50. So we're talking about going on the higher end of the spectrum on the levels. And that's a trough level you're talking about, right? Trough level. So
trough level
that's
80 to
the idea
100.
with valproic. You got to push that valproic to the higher levels. Because I had one kid on it and he's like on 25, level of 25. I said, we got to increase it. The mother was questioning me. I said, no, we're nowhere near where we need to be. And this was prescribed by a psychiatrist and it wasn't working. And the reason is it's at low levels. And so Dr. Tam and I, the child we're talking about.
Yeah, and I was going to say that if it's working at a low level, you can leave it.
Yeah, sure.
But if it's not, you push.
It's not. Yeah, push it. Yeah.
Yeah.
So that's the other thing, the nuance about valproic.
So that's the pediatric telephone hotline number. If you don't already have that written down someplace, 866-487-9507. You can talk to a child psychiatrist. We'll call you back within 24 hours. Any kid 21 or person 21 and under, we can talk to you about. Happy to just chat with you and kind of see if we can help you kind of think about options. Sometimes people call and ask, how do I change from this medicine to that medicine? Or what will be my next treatment choices to think about and talk about with the family? Happy to think through that. Or sometimes just thinking about, when do you need to go to therapy versus hospital versus residential, whatever. But we can talk to you about it in principle. Sometimes the details of what you have in your area is a different matter.
Well, I appreciate you. Thank you, Dr. Stock. Any questions from anyone? I think we went a little over, but that's okay. It was great stuff, and it's recorded, which is great for everyone who got on late. Obviously, we apologize for the mix-up, but we have this recorded, so everyone will be able to go through this on their own time. So thank you again, Dr. Stock. We'll look forward to next month, and Dr. Tam, do we have a date set for next month?
We do not. So once we have that set, we'll be sure to let you know, and I'll let you know once I have the video uploaded, and then also I'll send out a link for the survey for today's session, so you can go ahead and complete that to give us your thoughts. And yeah, sorry about the meeting, the Outlook link, but it looks like everybody made it over, so it worked out.
Good. Thank you. Thank you, everybody.
All right, thank you.
Thank you. Thank you.
Thanks. I look forward to seeing what cases you guys want to talk about.
Yeah, that'll be good.